Welcome to NOTeD, News of the Day, brought to you by the True Health Initiative, where we are going to ask in this segment, how is it possible that such a significant amount of nutrition-driven cardiometabolic disease is out there? Diabetes, heart disease, cancer, dementia, yet we've had to have a fight about coverage for dietitians that are the masters of that area. And with me today, we have co-host Kathleen Zelman, also on the board of directors of the True Health Initiative. Welcome, Kathleen.
Thank you very much. I'm happy to be here. And as a registered dietitian nutritionist, this is a topic that's near and dear to my heart. And I'm excited because not only am I the only dietitian here, but we have with us two of the experts that are helping the Academy of Nutrition and Dietetics make headway in this area. Our first guest is Marsha Schofield. She's a registered dietitian nutritionist, and she is the senior director, governance and nutrition services coverage at the Academy. And her job there is to provide us with leadership and oversight of how we can position members for success in this changing healthcare delivery and how we get paid. And Marsha's also an expert in reimbursement for our nutrition services. And she works with our second guest, Hannah Martin, to help expand coverage for nutrition services in both public and private markets. Hannah Martin, also a registered dietitian nutritionist, is the director of legislative and government affairs at the Academy. And her wide span of work includes being an advocate at the federal level, at the state level. She is constantly working on how to improve patient coverage for dietitian services. And interesting to note, besides doing all that, she's also working on her doctorate in public health. So welcome, ladies. Thank you so much for being here. I'm excited. But I think the first thing we need to do is define what is a registered dietitian nutritionist, because there are a lot of people out there that call themselves nutritionists that don't have the credentials that the three of us do.
That's right.
Sure, Kathleen, and let me go ahead and address that for you. I'm also delighted to be here. You know, the mantra that we have within the Academy related to that is that all registered dietitians are nutritionists, but not all nutritionists are registered dietitians. So it's a perfect question. You know, what sets us apart? The registered dietitian nutritionist, I might be dating myself, it's the gold standard. It's like the good housekeeping seal of approval concept for those of you who remember those days. But it's that credential that says we are the experts because we have completed a minimum of an undergraduate degree in food and nutrition. We've completed a supervised practice or internship type program. We've passed a national credentialing exam. And then we've maintained continuing education credits in the area to maintain our competency as those experts. Nutritionists, on the other hand, there's no standard credentialing, training, experience that goes behind that term. And actually, in a lot of states, there isn't even a legal recognition of what a nutritionist is. So, you know, you've got this gold standard where you can know there's experience and expertise and substance behind it. And then this other term that can mean lots of different things. And in some cases, a nutritionist may be very well qualified, but in some cases that may not be the case.
So the bottom line is always look for the RDN or RD. Are they the same? Dietitians can call, the credentialed dietitians can call themselves a registered dietitian or a registered dietitian nutritionist, correct?
That is correct, Kathleen. They're same terms.
You know, let me add too that as a board certified physician nutrition specialist, I have never practiced outside of a partnership with one or more dietitians in any practice that I have had. So if anything, as one of those rare physician nutrition specialists, my point is that I still needed to ultimately help patients in the best way possible to have registered dietitian nutritionists on the multidisciplinary care team with psychologists and exercise physiologists, but a core component of that transformational lifestyle change. So it's still befuddling to me, and you will clarify for us why it's such a challenge to have coverage for dietitians. Hannah, if you don't mind, can you give us a little bit of what you are doing in your role with the Academy and in the efforts to help facilitate what I see as obvious and logical need for coverage for dietitian services?
Sure. So a lot of my work in this area focuses on Congress, US federal government, and trying to expand coverage within Medicare in particular for medical nutrition therapy, which is the technical term for the services that registered dietitian nutritionists are providing for patients. And I can go into the background if you'd like, but currently Medicare only covers MNT or visits with a registered dietitian for patients who have diabetes or a kidney disease. And so if you're thinking, gee, that's a lot of people, but it's also a lot of people that are left out, you would be right. And patients who have other diseases or conditions for which you as a physician may want to refer your patients for a dietitian, that coverage isn't going to be there, at least within the Medicare space. So I focus my work a lot on that, whether it's lobbying Congress, working with the dozens of other organizations that support our work in this area, helping our members advocate with their members of Congress. So that's what my day-to-day looks like.
So just to reconcile the two terms, MNT is the acronym for medical nutrition therapy, for which clearly there could be for hypercholesterolemia, hypertension, type 2 diabetes, coronary disease, history of stroke, and the list goes on and on. You could argue dementia, at least in terms of cognitive impairment, cancer, et cetera, et cetera. Thank you.
So, Hannah, a question for you. It seems as though, according to CDC, almost all Medicare recipients have at least one chronic condition. More than 2/3 have multiple. So how is it that only diabetes and renal disease are covered?
We ask ourselves that question every day. The history of the benefit is that in the late 90s, we were finally able to convince Congress to study this issue, and they had what is now the National Academy of Science and Engineering and Medicine, but the IOM Institute of Medicine at the time to study this, study whether Medicare should cover a wider variety of chronic disease management services. And they issued a report again in the late 90s saying, yes, MNT is definitely something that should be covered. And then when it went through all the sausage making in Congress, they were really looking at this from a budget lens. Remember, this is only data up through the 90s, and the study of healthcare and public health science just wasn't what it is today. And so they said, okay, well, where do we think we can save the most money or spend the least money? And that was diabetes and kidney disease, which if you look at the end-stage renal benefit in Medicare, where anybody who ends up needing dialysis gets Medicare, there's a huge incentive for the federal government to try to prevent that by managing diabetes and chronic kidney disease. So in the late 90s, that was passed. The benefit came online in 2002, and we've been advocating a variety of ways since then to expand and are still working hard on that today.
And Hannah, I just adding to that report you mentioned from the IOM and that initial research, nutrition is a science. The science evolves like any science, like you mentioned. It's always interesting that the report planted the seed for other conditions like, potentially cardiovascular disease, but for a variety of reasons, just have not gotten traction up to this point in time on expanding it beyond that.
Well, it's interesting that during the pandemic, we saw how obesity was one of the highest risk factors, second to age. So people who are obese had the most complications and outcomes that were so poor. You would think that the government would see this as an important condition that allows for reimbursement and treatment by a registered dietitian nutritionist, because we know we can make a difference.
And we saw in New York, when the wave was coming through, hypertension as well, one of the most frequent and unbelievable to me, still not yet covered components. Question regarding obesity and the what might be some contextual coverage. Maybe you can clarify with the DPP the Diabetes Prevention Program, a massive randomized control trial of over 3,000 people who had prediabetes and were randomized to either a placebo, a drug called metformin, or an intervention, which was largely driven by dietitians, in which it crushed metformin by almost double the effect in terms of preventing diabetes. Is that not adequate evidence of the use of, now look, we realize that there's 90 million pre-diabetics and we can't have everyone seeing a registered dietitian, and therefore
Why not?
kudos to
Right?
well, hey, look, it's exactly. I mean, we should at least be maxing out the schedules, but I mean, I understand the need to get community members in and scale it through YMCAs and so forth. But why is not pre-diabetes which has a code, it has an ICD-10 code in multiple different varieties, based on randomized control trial evidence in a behavior change model, what have you? Why is that not covered? And how is, if at all, at least some private insurance coming up to step up the plate beyond Medicare to cover scattered, depends on your insurance plan, but some coverage for weight management and maybe pre-diabetes? Enlighten us on that.
I can take the first part on like logistically why it's not covered. So because of the way the MNT benefit was created in Medicare, Congress actually in law defined the service as being for patients with diabetes or a kidney disease. And so Medicare's hands are actually tied. They do not have the authority to look at this abundance of evidence and say, yes, look at this long list of conditions for which there is ample evidence of the effectiveness of MNT for older adults with these conditions. It actually requires a statutory change, a law to be passed to give CMS that authority or to directly expand the conditions. And so we're stuck there on the federal side, but as you alluded to, Medicare is not necessarily the leader in coverage in this area. And this is where my colleague Marsha is far more the expert on.
Right. And, Hannah will talk like we're pulling the lever to change Congress so we can change CMS along the way as well. And CMS, I mean, under Medicare, they do recognize obesity in what we consider some imperfect ways because they haven't put the nutrition experts front and center, or at least even given us enough space to be able to show how effective, or we know we're effective, but to apply that expertise to that major public health problem. But as Hannah said, while lots of times the rest of the payer world looks to CMS to set the standard, when it comes to obesity and even pre-diabetes, as you mentioned, with diabetes prevention programs, Medicaid and the commercial payer world have been far ahead of Medicare on that front. And actually, the Affordable Care Act was a big impetus for a lot of that because it set some requirements for payers in certain spaces. There's always loopholes, but to say you provide coverage for things that have the evidence to show that they're effective. So group called the U.S. Preventive Services Task Force sets recommendations for preventive services. They get graded. High grade items include screening and counseling for obesity in adults and children. It includes heart healthy counseling and dealing with risk factors for heart disease. And so we've seen in the Medicaid world and the commercial payer world more opportunities to access the RDN expertise. Not consistent, not perfect, but it's there, and it's even there beyond those things. But certainly what you've mentioned, Tom, the rest of the world has forged ahead beyond where Medicare is.
So and I just wanted to,
yes,
if I could add one more thing, Medicare does cover the diabetes prevention program, which is a group lifestyle program. And many of those programs are conducted by RDNs or managed by RDNs with other healthcare providers or lay health educators doing the delivery. And this is another area we advocate on because there are a lot of challenges with that benefit. It's extremely underutilized. It's been very challenging to get suppliers in because of the payment and the hurdles to become a supplier. And we think we're finally getting through. We actually are seeing some stuff in a rule that just came out a few weeks ago for next year's physician fee schedule. So we think there will be improvements in access in Medicare, but that is, just the DPP group intervention.
And are pre-diabetics or people with pre-diabetes eligible?
Yes, so that program is specifically for people with prediabetes with the goal of preventing diabetes, which, as Tom said, it was highly effective in doing in all the trials and has continued to be effective in the real world.
Yes, there were 3 world trials from Finland, from the United States, and in Asia that all showed the same, almost same exact number, around 60% reduction of type 2, converting to type 2 diabetes. If I may say, as I had a role in a large healthcare system of helping train some of the DPP coaches that system was using. And I advocate for group coverage of grocery shopping tours by dietitians. They are particularly effective. You're right there on the ground. Things get to be asked that are really pull off the shelf, and the patients can guide hey, how about this? And it's right on the spot. So, and I'll vouch for the validity of that. And if you need a randomized control trial for that Medicare, you've lost your mind, because there's some things that just can't go through a randomized control trial but are obvious. I will not bring up the fact that smoking has never been put into a randomized control trial to prove it causes lung cancer. And if you don't think that it does, then maybe we just can stop talking now. In terms of the U.S. Preventive Services Task Force, as I understand it, if a recommendation is at level A or B, then it must, according to the Affordable Care Act, the insurers are compelled to cover it in some way, shape, or form. Hopefully that's helpful, because as you said, Marsha, I believe you mentioned there's prediabetes, cardiometabolic risk, as I call it. I can't remember exact terminology, but hypertension, dyslipidemia, and obesity itself are all items that are screening is covered for, and then referral to. Now, I've always questioned, okay, now I've referred. Now, does that mean are you going to cover the referral part, or are you just paying them to refer them? But what you're saying, I think, is that there has been actual coverage for group programs for diabetes prevention, which often, but not necessarily, dietitians are involved in the process. Is that a summary?
Absolutely. And a couple little caveats related to that, because I always say, healthcare isn't designed the way I would design it. Coverage isn't designed the way I would design it, but that's what we're working towards. That referral piece is an interesting one, and it's a sticking point that Hannah can speak to as well, in terms of where we are with things. Because, for instance, under Medicare, we have that exact problem with their coverage for obesity. They have a benefit called intensive behavioral therapy for obesity. And if the physician refers to a dietitian for that service, which would align with the U.S. Preventive Services Task Force, the payment doesn't follow. And so that's a problem. Or even when we talk about what the Affordable Care Act did, there's a lot of insurance products that are exempt from those requirements. So, for instance, benefits designed an employer who has a self-funded plan, they're not bound by that. Those requirements really apply to Medicaid and individual coverage or small group coverage in the marketplaces that were created as a result of the Affordable Care Act. So it's helped tremendously, but there's still loopholes.
I'll also add that the enforcement of that coverage is left up to the state level, often the commissioner of the Department of Insurance. And as you can imagine, in a post-ACA, all of that implementation that they had to do, that making sure the thousands of individual health plans that were theoretically supposed to be subject to these regulations and requirements, that's not making the top of the list at a lot of departments of insurance. So we have worked with our members to get meetings at the state level and say, hey, we just wanted to bring this up, like we're actually checking and it's not necessarily being covered, or one visit checks the box, even though USPSTF is recommending 20 plus visits in a year for obesity. So there's, even where on paper it looks like there should be coverage, when you actually get down, you're the patient, you're the provider, lots of stuff starts to break down.
It's really sad that we have proven through multiple studies the effectiveness of RDNs, and yet we continue to struggle. but there's hope on the horizon, is there not? Tell us about the bill that's in Congress and what potentially lies ahead.
Sure. So we have been working with a dedicated group of senators and representatives and have, for the second Congress in a row, introduced the Medical Nutrition Therapy Act. So the MNT Act for short, this time around is co-sponsored by Senators Collins and Peters and Representatives Kelly and Upton. So we've got our bipartisan group all around. All of these folks have been really supportive of dietitians and MNT and preventive services in general. And the bill would do a handful of things. And the first is it would greatly expand the list of conditions that are proactively covered. And we think that's important because that gives CMS that direction to move in. So, day one, as soon as the bill is enacted, if it were to pass, they could start working on having coverage for cardiovascular disease, prediabetes, cancer, eating disorders, malnutrition. There's about a dozen conditions in the bill. So that's the big enchilada, if you will, in the bill. But to go back to my earlier point about CMS's hands being tied because of the way the benefit was originally created, there's also a piece of the bill that explicitly says the Secretary of Health can add additional conditions in the future as long as it's aligning with recommendations from USPSTF or prevailing clinical guidelines. So really giving CMS that authority, like they have for so much of the coverage and the benefits they have, to work with the experts like the Academy and other healthcare groups, provider groups, to say, well, what is the evidence? What should we be covering? And make those changes without having to have a literal act of Congress. And then the last main piece of the bill is it would tweak the referral piece. So right now you have to have actually a physician, so MD or DO, writing that referral, which maybe made sense in 2001 when they were writing the benefit, but with the huge rise in NPs and PAs and other provider types, especially in the primary care setting, you have patients who may be in rural or medically underserved areas or maybe in a city seeing those other provider types. And even if they can legally practice and legally refer patients in their state, they cannot for MNT. So essentially, if you have a patient who does have obesity and hypertension and prediabetes, and they go to a practice run by an NP, they're locked out of the existing benefit.
So Hannah, is this bill focused primarily on Medicare, or is there a wider berth or wider scope of application beyond people who are 65 and older?
Yeah, so this specific bill is just looking at Medicare Part B. So it's just those folks who have Medicare. We have worked on some state legislation as well. There certainly are Medicaid programs covering this as well. And Marsha always speaks better about this than I do, but Medicare in many cases is a standard bearer for the insurance industry. It's not surprising that when you look around, one of the most common things that state Medicaids cover for MNT is diabetes, which is in the Medicare coverage. So we certainly expect that even though this bill on day one would only have an impact on Medicare itself, that there would be a trickle down effect as private payers, Medicaid, et cetera, are looking at the changes Medicare made and saying, oh, okay, we trust them. We'll do something similar.
Hope and actually hopefully a downpouring effect, because something you mentioned was that both, if I'm not mistaken, Fred Upton, a Republican, and Gary Peters, a Democrat, by the way, both from Michigan, which is where I'm at right now, and they will be getting calls from me right after this. I've actually
Tom.
Call them to thank them. It's important to tell your members of Congress you're happy with them, not just when you're unhappy.
No, I actually have good relationships with both offices, and to be honest with you, I'm somewhat embarrassed, and thank you for enlightening, because the real reason we brought you on is just so I get to know more, not just everyone who's watching. We have a large audience that's going to be benefiting from this. So by all means, if there's a way that they can learn who is a particular, and it may be someone in their state, one of their representatives, that they can call, because that might have the most influence since they would be a constituent. But even otherwise, if someone is not sponsoring there is no one from a particular person's state or district that they can still voice their opinion. My point is that this is a bipartisan issue. This is how rare do we have it today where there is something in which there's really not a battle line drawn over what party you're in. I mean, yes, there it is. That whether it's COVID or it's an atheroma, a plaque in your coronary artery, it's not checking your card. What party are you in? We have members of both parties that are interested in helping this come along, and hopefully it will be a downpouring effect, because historically, if Medicare has covered something, there has been some influence, let me not say pressure, but whatever the term you want, that others will come around and say it's been through a vetting process. If Medicare is covering it, so should we. But then there's the issue that we would like to ask about, which is how can patients be advocates of their own, in their own insurance plan? And who can they call? How would they speak to the customer representative on the other end, potentially getting to as high of a level as necessary? Because let's face it, some people are really just doing their job and they're fielding calls and they're taking all this venting. And maybe we should say, can you get me to this such and such person, this ombudsman or whoever it may be, that I can express, I was going to say unleash, I can express my concerns upon. Is there any recommendation you have in that regard of how to advocate from within our own insurance plan, how to encourage a better coverage of registered dietitian nutrition expertise?
Sure, Tom. And I laugh with that, but also think about even with Medicare, but we certainly see it in state advocacy efforts. Sometimes people just, like the decision makers, assume it's covered. They don't realize it's not there. So I think, Hannah has probably found in working with the bill co-sponsors and everything that people are like, what? It's not there? Like, I didn't realize that. And we see that, with Medicaid, we see that with commercial payers as well. But certainly we're all in this together, right? It's not just the Academy of Nutrition and Dietetics and RDNs advocating. We've got our physician friends such as yourself, and others who are out there, but the consumer itself has a really strong voice in the conversation, because what's one of the things that at least a commercial health plan wants to do? They want their members happy, so they continue with that plan instead of saying, hey, I'm going someplace else to get my coverage. So, yes, I can call my own health plan and say, like, what do you cover? And if you don't cover it, this is what I want. The person who first answers the phone is not the person to do it. And often it is really challenging to get up the chain of command. But a medical director is a really good person to try to get to, for instance, or whoever's over the network and credentialing of providers, because maybe they say, yeah, we cover nutrition, but we don't have dietitians who are doing it. And you can say, I want dietitians, access to dietitians. So that's, two ways that I think are certainly helpful to go, in a commercial plan. The other thing that's really important to keep in mind, and I referenced it before, there's like 50% of us out there who get our health care through an employer. And the last statistic I read, I think, was 2019, that 61% of those plans are employer funded. So that means my employer is designing my coverage and benefit package. So perfect opportunity to go to like your human resources manager and say, I want coverage. We did that within the Academy of Nutrition and Dietetics. It's like, what do you mean we can't access MNT by an RDN? We're the professional association. And so we worked to get coverage. Anybody can do that with their employer. And that's a huge market to tap into. The Medicaid side, it gets managed, it gets regulated differently. You have to go to your state agency that oversees a Medicaid program and get to the medical director. Those names are easy to find with an internet search. Getting to the names in the commercial market, it's a little harder to use, the powers of Google and others to get to those people. But yeah, you can push. It's
go ahead, Kathleen.
So Marsha, we talked about how you, as a patient, you can be an advocate. What about the healthcare team, members of the healthcare team that want want to be able to bring on an RDN into their practice, but they want to be able to get coverage for him or her? How would they advocate for it? And are there resources that the Academy provides that either a patient or a professional can download, look at, better understand what the coverage is? I mean, you guys are experts. These people just want coverage. They want what's their due. Are there resources that we can point them to?
Sure. Hannah, maybe I'll start and then you can add on to it as well. I think I would love to be doing this in partnership, and we have lots of examples where, we work with other healthcare professional associations on the national level, or dietitians just, Tom talked about dietitians on his team. So in practice, we're in this together, and I think we are more effective if we all work on it together. I think because of the volume of the physician and other, physician assistants, nurse practitioners, that workforce, it's a huge voice that payers listen to along the way. And so absolutely, we want and need everybody beating the drum and carrying that message and saying, my patients need access to this critical service, this expert provider, and this is what we need, and please help to make it done. Yes, the Academy has resources. We have volunteer leaders that are positioned to help work and partner on advocacy efforts. We have toolkits and resources that train them, and others can access. We have a Medicaid advocacy toolkit that helps people walk through that. We have lots of leave behind pieces for various stakeholder groups that get the message out there on what's the value of this. Why should you add this to your benefit package along the way? Those are available to everybody. And we can share links to those resources because we can carry that same message along the way. Hannah, what would you like to add to that from your
Yeah,
angle
I
of the
can
work?
add about federal advocacy, specifically on the MNT Act. So we always are pushing out to our members what we call action alerts. So this is, you go in, you put in your name and address, and it just pops up your members of Congress, your representative, and your 2 senators. And we have a pre-filled letter that you can edit however you want or not, and send to them requesting that they support the Medical Nutrition Therapy Act. So I think we're going to put a link to that somewhere on the site wrapped around this. But that's one thing that individual providers who believe strongly in this can do. And then for those who are in leadership positions in those organizations, I actually have a group, a coalition of about 4 dozen organizations that are these national organizations that are explicitly supporting the MNT Act. And a group of those actually, we meet monthly. We just recently did group advocacy. So going virtually, but virtually to the Hill to advocate on this bill. And we have toolkits on how to do that advocacy within your organization. We even have a form letter if you want to request that an organization send a letter up to, the representatives over where their headquarters are, or whatever members of Congress they may be close with. So certainly with getting other provider types, and especially in the case of my work, other associations involved, we really try to have a no wrong door, no wrong level of support. We have everybody from folks who say, yep, I can sign us on, but don't have the bandwidth to do more, to others saying, hey, we'll do our own action alerts. We'll set up meetings. We will lead teams to lead other organizations to do meetings. So yeah, fabulous is the exact word. Every time I think like, oh man, in a year, we got almost 50 other organizations supporting this bill, and
you guys,
continues
that's
to
great.
grow. It just shows that it's not just dietitians saying, oh, we need coverage for our services. It really is the whole healthcare team saying, this is a piece of care, and a lack of coverage or insufficient coverage is really a barrier to providing good care to patients.
Well,
You know, and-
especially when you think about how much money we spend in healthcare. I think I saw on something I read from you, Hannah, that it was $3.8 trillion. That's the annual healthcare budget, that 90% of it goes towards treating these chronic and mental health conditions. And we know food is medicine. So we really have to, I think you've made it perfectly clear, it takes a village and we all have to take responsibility. We want everyone who's listening to call their congressman, fill out this paperwork, make it as easy as possible, but do your part, because I think it has great legs and great opportunity that, maybe next year, this time we'll be talking about all the additional conditions that now are being reimbursed for the services of an RDN.
So well put, Kathleen. Thank you for that. And also, can we get the website address and confirm for me also that if someone simply wants to search and find a registered dietitian, you have that type of search engine available. So could you give us, number one, the website address, and to be clear, correct, if you happen to scroll down the beautiful written piece that we've wrapped around this and just hit play on the video, the hyperlinks to these will be embedded in the article. So go back and read that part too. But what is the web address? And just wanted to point out too, that if you want to cut right to finding a dietitian and you just want to pay cash for it, well, by all means, that's money well spent as well.
Absolutely.
So if you go to www.eatright.org, that's our consumer website, right upper right-hand corner, find a nutrition expert. And the beauty of it is we just recently revamped that tool. And so you can search for somebody who provides services via telehealth. You can say, like, do they accept insurance? Are they a Medicare provider? Maybe your state Medicaid program, commercial. You can pick a specialty that you're looking for, or you can just do a general search by zip code along the way. So the RDNs are out there, and that's an easy way to find them.
And when I've searched it, because for full disclosure, I've searched it many times helping people find dietitians, what they might specialize in is also listed.
Right. It's unfortunate. Lots of times we hear even physicians saying, like, I don't know where to send my patients. I don't know where, a dietitian is. There aren't any around. And it's like, they're there. We're trying to make it easy for you to find us.
And thank you for all that you're doing. We promise on our end, as I'm speaking here with 3 dietitians, but we promise on our end, and I will be making those phone calls. So if you watch this, make those calls.
Yes.
Marsha Schofield and Hannah Martin of the Academy of Nutrition and Dietetics, thank you. And thank you, Kathleen Zelman, for being a great co-host on this NOTeD. We look forward to having you co-host more of these as we progress forward with the True Health Initiative on NOTeD. News of the day brought to you by the True Health Initiative. Thank you all so much for being here for this great, really great informative segment.
Thanks for having us.
You.
Call your congressman.
Take care, everybody.